هتقدم لنا approach to the child with recurrent fractures.
بسم الله الرحمن الرحيم. بشكر دكتور هشام على التقديم الجميل، ربنا يخليك. وبشكر الأخ والصديق العزيز أستاذ دكتور أسامة حسين على دعوتي. الحقيقة أنا بحب جدا إن أنا أبقى موجودة وحريصة إن أنا أبقى موجودة في المؤتمر ده. بسعد جدا، حقيقي بيلمنا يعني مع بعض الدكتور أسامة، وبيبقى فيه very high quality scientific content وtopics جميلة وبرفكت organization، حاجة رائعة، الواحد حريص فعلا إنه يكون موجود فيها يعني. ومبسوطة قوي بوجودي مع حضراتكم النهارده. هتكلم عن approach to the child with recurrent fractures. والحقيقة أنا اخترت التوبيك ده لأن هو مش بس اندوكراين، لا هو في حتة اندوكراين لكن داخل فيه حاجات تانية كتيرة لينا كبيدياتريشنز. مش عارفة شغال؟ أوكي. When we face a child with recurrent fractures، أوبس أنا كان هيحصل لي fracture دلوقتي. في سلمة تحت. When we face a child with recurrent fractures, the questions that pops out to our mind, is it a coincidence or a disease? And this is a real challenge because when managing children with recurrent fractures, every step counts because there's a great difference in the approach, in the diagnosis, in the management. It affects the whole life of the child. The bone strength results in a balance between bone formation and bone resorption, and if this balance is impaired, bone strength is affected. Now, looking closely at the rank L OPG or osteoprotogerine system, rank L binds to rank, and this stimulates osteoclastic differentiation, and this will result in bone resorption. On the other hand, OPG binds to rank L, inhibiting osteoclastic differentiation, which results in bone formation. So it's like an orchestra maintaining the perfect bone strength balance between bone formation and bone resorption. So looking at the rank L OPG ratio, what happens is increase rank L rank, bone resorption, and decreasing osteoprotogerine decreases the bone formation, and this will end up by osteoporosis and bone fractures. The bone strength is affected by a lot of factors. The components are the bone quantity and the quality. The bone quantity is represented by the bone mineral density, and the quality depends upon the material properties like the bone mineralization, collagen, proteins, and micro damages in the bone. And the structural properties affected by the bone geometry and the microarchitecture. And there are a lot of determinants of the peak bone mass, which is acquired nearly at the age of 16 to 25 of age. We have nutritional factors like vitamin D, calcium, and protein, hormonal factors, mainly sex steroids, growth hormone, IGF-1, mechanical factors, and genetic factors. And in fact, these factors are working together to achieve the peak bone mass. And please remember that the peak bone mineral density is acquired with the growth spurt. In boys around the age of 14 and in girls around the age of 12. So timely induction of puberty is very important for acquiring the normal bone mineral density and geometry. And that's why adolescents having delayed puberty and hypogonadism are liable to fractures and osteopenia. In this table, you can see the risk factors and the causes of fractures. Looking at the medical conditions, we have inherited connective tissue disease. On top of the list, osteogenesis imperfecta, idiopathic juvenile osteoporosis, chronic inflammatory disease like juvenile arthritis, inflammatory bowel disease, sarcoidosis, GRA, any chronic illness like liver, kidney disease, cystic fibrosis, celiac disease, neuromuscular disorders like CP and muscle disease, hypogonadism, whether primary or secondary or associating thalassemia, drugs like steroids and anti-epileptics, phenytoin being on top of the list, and finally, some endocrinal disease like type 1 diabetes and hyperthyroidism. So what is the approach to a child with recurrent fractures? First of all, if the child has got history of fractures, whether vertebral or long bone fractures, the presence of a vertebral fractures necessitates assessment of bone health. This is pathological. Vertebral fracture is a pathological condition. What about the long bones? If 2 or more long bone fractures by the age of 10, or 3 or more long bone fractures by the age of 19, or bone mineral density less than 2 standard deviation for age, sex, and height, we must assess the bone health. On the other hand, if you have less than 2 long bone fractures by the age of 10, or less than 3 long bone fractures by the age of 19, you just give sufficient calcium intake, increase vitamin D more than 50 nanomoles per liter, and exercise weight-bearing activities. And this is the proposed algorithm by International Society for Clinical Densitometry for Pediatrics. Now, how to assess a child with recurrent fractures? The clinical part is very important. Assess history of fractures, pain, musculoskeletal examination, exclude chronic disease, exclude child abuse because it could be part of child abuse, measure weight and height and plot the child on the growth chart, TANA staging, and estimation of dietary calcium. And then we do the lab assessment. Serum calcium, phosphorus, alkaline phosphatase, 25-hydroxy vitamin D, and serum parathyroid hormone. Plain X-ray and Dexa Scan, very rare to do genetic testing in some types of osteogenesis imperfecta, and very rare to ask for bone biopsy. But this is the general plan for any child with recurrent fractures. Now, looking at the vitamin D status, of course, 25-hydroxy vitamin D is the most important diagnostic test to assess the vitamin D status. We cannot rely on 125-dihydroxy vitamin D because the half-life is very short. We only do it if we need to assess for vitamin D resistance. So if you have normal 25-hydroxy vitamin D with low 125-dihydroxy vitamin D, this is a defect in 1-alpha hydroxylase. Normal 25-hydroxy vitamin D and high 125-dihydroxy, this is resistance or defect in vitamin D receptor. And these are the 25-hydroxy reference guidelines, vitamin D from various organizations. You're going to notice there are some difference in the definition of vitamin D deficiency and insufficiency. We follow the Endocrine Society guidelines to define vitamin D deficiency and insufficiency. And vitamin D toxicity is defined when vitamin D 25-hydroxy exceeds 150 nanograms per ml. Another important question, what is the difference between osteopenia or osteoporosis? In osteopenia, the bone mineral density is lower than normal. So this is the mineral part. Here, vitamin D, calcium, and minerals. What about osteoporosis? Low bone mineral density plus disrupted bone microstructure and protein content. So if we ignore osteopenia, it's going to progress to osteoporosis, which is more severe because in addition to calcium, vitamin D, and minerals, the protein part is affected as well. Let me tell you that Dexa Scan, which is the dual energy X-ray absorptiometry, is the gold standard tool for assessment of bone mineral density. It diagnoses osteoporosis, and in the report, you're going to see the bone parameters and the body composition parameters. And this is the WHO definition for the bone mineral density status. In children, we rely on the Z score. If the Z score is less than -2 standard deviation, this is low bone mineral density. In young adults and in adults, we rely on the T score. And here you can see if the T score is between -1 to +1, this is normal. -1 to -2.5, this is osteopenia. And less than 2.5, this is osteoporosis. And this is a photo of the real report of how the Dexa scan looks like. It's very easy to interpret. If you look here, this is the total body Dexa scan. If it's more than -2, this is normal. And this is the lumbar spine Dexa scan. Again, you can see the numbers, the T scores and the Z score. If you are more than -2, this is normal. And this is the neck femur Dexa scan. Again, look at the T score and look at the Z score to interpret. There are a lot of advantages of the Dexa scan. It's precise, it's easy, low level of radiation. It's less than the plain X-ray that we do normally, accurate description of bone mineral data, and this makes it the gold standard method for assessment of bone mineral density. But there are some limitations of the Dexa scan in children. First, and this is the most important, the current lack of standardized pediatric normative database. And we are working on a project of establishing normative data for children and young adults in Ain Shams University, starting from day 1 until the age of 18, to have our own data for the Dexa scan in Egyptian children and adults. Also, inaccuracy resulting from growth-related variation of the bone, body size, and composition. It's very important to correct the Dexa in relation to the height of the child, because if you have a short child, you're going to have lower Dexa scan parameters. So it's very important to be corrected for size. Vertebral fracture assessment is a bit different. We rely on plain X-ray spine rather than Dexa scan. So if you have a child with back pain or fractures in the vertebrae, it's better to do plain X-ray spine rather than Dexa scan. Also, we as pediatricians, very important to exclude child abuse. If you have a child with a lot of fractures, yes, it could be a pathological disease, but very important to exclude child abuse. And here you will see evidence of neglect, discrepancy between history of the fracture severity and mechanism, suspicious skin injuries like burns, bruises, bites, look behind the ears, genitalia, and take photos if possible. And this is highly suspicious if the child is less than the age of 6 months or even 1 year. And here you can see how fractures due to child abuse appear. You can see the burns, you can see the multiple fractures, the bucket handle fracture, the ribs, the acromion, very suggestive of child abuse. And the management of osteoporosis, we have the general measures. Treatment of the cause is very important. Diet rich in calcium, vitamin D, encourage exercise and weight-bearing activities, treat vitamin D deficiency, calcium, anti-inflammatory drugs if there is severe pain, judges use of bisphosphonates, and sometimes calcitonin. So let me show you this very nice tool of treatment of osteoporosis, bisphosphonates. It's very important to use it carefully. Bisphosphonates inhibit osteoclastic activity and they promote osteoclast apoptosis, and so they will stop bone resorption and help in bone formation. And there are some insights in the treatment of osteoporosis which are very new. This is denosumab, which is a monoclonal anti-RANKL antibody, which binds to RANKL, preventing it from binding to osteoclastic receptor. And the net result is decreasing osteoclastic activity and decreasing the bone resorption. Also, sclerostin inhibits LRP5-WNT system, which inhibits osteoblastic differentiation, decreasing mineralization. So if you give anti-sclerostin antibody, here it binds to the receptor and stimulates osteoblastic differentiation, helping in bone formation. Another modality is the TGF-B1 neutralizing antibody, which poses a balance between bone formation and resorption, helping in remodeling of the bone in a proper way. Another thing is recombinant parathyroid hormone for steroid-induced osteoporosis. It's not available in Egypt, but hoping that it will be available soon, but it has got good results and a lot of research on it abroad. It blocks rank L. Again, it decreases osteoclastic activity, decreasing the bone resorption, and stimulates the osteoblast as well. Let me very quickly share with you some cases with recurrent fractures. In all of them, fractures was the main presentation, but the scenario turned out to be totally different. Let me start by Fatma. She's a 10-year-old girl who came with recurrent fractures. 5 fractures in 2 years. As you see, the girl has got bowing of her legs and decreased hearing. She's short. Her sclera is normal. Dentinogenesis imperfecta. Look at her teeth. Thin cortices, and you look here, there is marked osteopenia, bowing of the bone, and this is what we call codfish vertebra. The vertebra looks like a fish. What's your diagnosis? What do you think of this girl? Thank you, yes. This is type 4B osteogenesis imperfecta. And for us as pediatricians, it's very nice to know it is just osteogenesis imperfecta, not necessary to know the type. So, and this is when I asked Fatma to draw what she felt. She drew herself crying, imprisoned at home, and the rest of the kids are playing in the sun. It's a very handicapping disease. It's very important to shed the light on such disorders. And this is Malika, a 4-year-old girl with recurrent fracture since birth. And when I asked the mother, how frequent did she experience fracture, she said, I couldn't count the fractures. It's part of her life. As you see, she's got severe deformities. She's very short, blue sclera. The teeth are spoiled, dentinogenesis, osteopenia. And if you look here, this is a callus formation. Here you can see typical codfish vertebra. It's typically like a fish if you look at it. This is what we call popcorn appearance at the ends of the bone, and again, callus formation. This is severe type of osteogenesis imperfecta, type 3 osteogenesis imperfecta. Osteogenesis imperfecta is an ancient disease. It's not new. And the earliest OI case was a partially mummified Egyptian infant skeleton dating since 1,000 years BC. And by the way, it's found in Cairo Museum. So this is an ancient disease since the time of the pharaohs. And what simply happens in OI is impaired collagen synthesis, or folding and cross-linking. And this is the modified silence classification for the types of OI. We all know the classical 4 types, but right now, a lot of emerging genetic mutations appeared with more than 15 types of osteogenesis imperfecta. But as I told you, as pediatricians, we need just to take care that this could be a child with osteogenesis imperfecta. So OI is a model representing various spectrum and severity of disease. Some of them experience fracture once or twice in life, and some of them have uncountable fractures like the one I showed you. And this is the checklist for OI and Ain Shams University protocol of how we deal with cases of osteogenesis imperfecta. In fact, it needs a multidisciplinary team. The pediatric endocrinologist, and of course, the orthopedic surgeon, the otolaryngologist, the physical medicine specialist, a child psychiatrist, because they pose a lot of psychological burden for these children. A lot of doctors working together to improve the quality of life of those children. And here, this is a quite recent article on current concepts in OI, structure, biometrics, and management. It's clear that the current treatment of OI focuses on vitamin D, calcium, and bisphosphonate. Bisphosphonate is the golden tool for treatment of those children. It improves the quality of life and reduces the fractures a lot. And these are the doses of the bisphosphonates, as you see, the zoledronic acid and the pamidronate. We use the zoledronic acid and the results are excellent in those children. Of course, we need to increase the calcium requirements for those children and give prophylactic vitamin D. And this is a research that we conducted at Ain Shams University assessing anthropometric and nutritional data of Egyptian children with osteogenesis imperfecta. 84 patients were recruited. Of course, we found significant lower height, SDS, growth velocity, and sitting height in those children. And our research found there was a significant improvement in the height and growth data in those who were treated with zoledronic acid. And there are some trials of giving growth hormone in such children, but of course, it's not FDA approved until now. Now, let's leave the osteogenesis imperfecta and go to this boy. Yusuf is 10.8-year-old boy with bow legs. He's short. He has bilateral bowing of his legs since 2 years, bone pains, 1 fracture. His parents are consanguineous. He has palpable sagittal suture and a small dental abscess. No other rachitic signs in this boy, just bowing. Look at the x-rays. Bowing, osteopenia. Here, yes, rachitic manifestations in the epiphysis, and this is the craniosynostosis. Now, look at the lab profile of this boy. His calcium is lowish. It's not low, but in the low normal. And so the parathyroid hormone is in the high normal. His phosphorus is very low. Alkaline phosphatase is very high. 25 hydroxy and 125 hydroxy vitamin D are normal. And tubular reabsorption of phosphate is very low. And the blood gases is normal. What's your diagnosis? What do you think? Very low phosphate? Yes, thank you very much. This is hypophosphatemic. مش مشكلة ما هو في. Yes, yes, but this is a boy. This is a true story, by the way. This is a case, really. Yes. أنا شفت شوية ميلز بقى. موجودين. This is a case of hypophosphatemic rickets, okay? So when you have a case of low serum phosphate, measure the PTH. If high, could be abnormalities in vitamin D metabolism, calcium deficiency, primary hyperpower. If you have normal or low phosphate, don't forget to measure urine phosphate. If low, this is low intake phosphate malabsorption or increased extrarenal removal. If high, خلص دقيقة واحدة. Measure FGF23. If high, hereditary hypophosphatemic rickets. So excess FGF23 causes XLH with its symptoms, and in XLH, we have conventional phosphate therapy, vitamin D, and neurosurgery, and there is a very new treatment called burizumab, which inhibits FGF23, and it changed the life of those children. Now, Yasser is a case of juvenile rheumatoid arthritis on steroids. If you look at the profile, the calcium is low, vitamin D is low, and the total bone mineral density, lumbar spine, Z-score is very low. Here you can see very low Z-score. And what are the causes of reduced bone mineral density here? The steroids, the short stature, and the hypomonadism. What is the most important radiological investigation? If I tell you the boy has got back pain, what would you like to do? Plain X-ray spine, simply. This is the most important tool. Look at the spine, damaged spine, vertebral compression fracture and loss of height and deformity. The boy was given bisphosphonate, calcium, vitamin D, and don't forget to treat hypogonadism. So vitamin D, calcium, and bisphosphonates are given to those children. And this is the last case, a case of cerebral palsy, and the boy here has recurrent fractures. He's very short, muscle atrophy, not compliant on physiotherapy, and he is on anti-epileptics. The calcium is low, the vitamin D is low, and the parathyroid hormone. And here you can see the Dexa Scan is very low. He has got severe osteopenia. And X-ray, you can see osteopenia and decreased vertebral height and compression fractures. So the cause here is short stature, low BMI, immobilization, muscle atrophy, and of course, dipykine is an important cause of osteopenia. Here, the boy was given bisphosphonate, nutritional support, vitamin D and calcium, and physiotherapy. So there are a lot of stories to speak about. This was just a taste of children coming with recurrent fractures. And finally, I think that those children have got different cases of recurrent fracture, but all of them share the same story of the challenge and the quality of life. Because a lot of children and adolescents encounter fracture, and this affects the quality of life. I think that those children deserve special attention from us as pediatricians. My final message is assessment of bone health in children and adolescents with recurrent fractures is very important in order to achieve a better bone health for our growing children and to overcome the heavy burden of recurrent fracture and to see the happy faces of those sweet, lovely children. Thank you very much for your attention. سرعته على قد ما بجري.
شكرا للأستاذة الدكتورة رشا طريف. الحقيقة دكتورة رشا دائما متألقة حتى أنها تستحق فعلا لقب أميرة البيدياتريك اندوكرينولوجي في مصر أو أميرة القلوب في البيدياتريك اندوكرينولوجي في مصر. شكرا يا دكتورة رشا، ألف شكر. ربنا يخليك، ألف شكر. الحقيقة كل الشكر والتقدير للأستاذ الدكتور